Thank you so much for joining us today and welcome to today's webinar, Value-Based Healthcare and its Impact on Credentialing, Privileging, and Quality. We're so happy you were able to join us. I'm Sharon Beckwith, President of Peer Review and Clinical Quality Consulting at the Hardenbergh Group, and I will be the moderator for today's program. Today's webinar is being sponsored and hosted by the Hardenbergh Group. Before we begin, we have just a few housekeeping details to share. All attendees' microphones have been muted for the presentation. If you would like to ask the presenters a question, please just click on that Q&A icon. Usually it's at the bottom of your screen, could potentially be at the top, depending on how your screen is organized, and just type your question in there. As time permits, at the end of the program, we'll go ahead and look through those submitted questions, and I'll be able to pose those questions to the presenters, and we'll get to as many as we possibly can. Just a reminder, your NAMSS-approved CE certificate will be emailed to you within 48 hours. That email will come directly from the Hardenbergh Group in your thank you for attending follow-up email. We will also include in the email the slides from today's presentation. I know that a few of you have already asked if you will be receiving those slides. Yes, you will. And I also see questions just about being muted. Yes, you are muted for this presentation. So again, if you have any questions, please put them in the Q&A. So in the follow-up email, there'll be a link to a survey as well, a short survey. We'd love it if you just take a few minutes to share your feedback. So now it's my pleasure to introduce today's presenters, Dr. Mark Smith and Joni Orand. Dr. Smith is the Chief Medical Officer of the Hardenbergh Group. He brings over 30 years of clinical practice experience and hospital management experience to his work with physicians and hospitals nationwide. He's a clinical professor of surgery in the vascular and endovascular surgery section at the University of California, Irvine. He has expertise in system quality and performance improvement, peer review, OPPE, FPPE, and management of deficient provider performance, criteria-based privileging, low-volume providers, ED call, and external focused review. So a lot of experience that he's able to share with us. Joni Orand has worked in the healthcare industry for 30 years in both managed care and hospital environments, working with payers, provider, and staff, gaining unparalleled experience in all aspects of operations, revenue cycle management, provider data management, quality improvement initiatives, and outcomes. So super excited to have them both with us today. And now I'd like to turn it over to Dr. Smith and to Joni. Thanks so much.
Thanks, Sharon, and welcome everyone. Either good morning or good afternoon, depending on where you're at. Joni and I are really excited to present this topic, which we think is going to hopefully be impactful, although a little bit off of what the normal topic areas that we present in these webinars. So I guess you could say we're doing a little off-roading today, but we really want to get into the topic of value-based healthcare and the impact that it has on our organizations. So to that end, we can ask the question, what is value-based healthcare? And hopefully we can explain what that is and give you some ideas about approaching it in your organization today. Many think that this is a buzzword that's come about in the last year or two, but it's actually been around for a really long time. Historically, you could say it started when we created medical managed care back in the 1980s, but that first go around really failed because it wasn't providing the options for patients that they really require. So it sort of took a step back in the managed care realm, but continued to develop over time. Certainly employers looked for ways to cut down on healthcare costs, and so did the US government. And it really rose again, and you could see it culminate perhaps about 10 years ago or more with the American or with the ACA legislation that came about, the so-called Obamacare. So with that, let's go into what is value-based care. And it really starts with this equation. It seems simple, but it covers a lot of territory. That value in healthcare is really a combination of the quality that's delivered times the perception. So there's both an actuality in the quality that's delivered. What do you get with your outcomes? How do you actually improve healthcare in a measurable fashion? But there's also a perception component to it. What do the patients perceive as the healthcare improvement that they're getting, or the value that they get from their healthcare interactions? It's divided by the cost. And you can see historically that healthcare providers really centered on the quality area and a little bit on the perception, while healthcare administrators tended to look at the cost. And what we're realizing is that this has become a continuum and is really part of the same system. So we have to conceive of this as a totality. So what is the definition of value-based healthcare? It's really hard to come to a single definition. We don't usually utilize Wikipedia, but so much of the world will go to that we thought we'd throw in the definition that Wikipedia has for it. And you can see that it's essentially a restatement of the value-based equation. But you can also say that value-based programs reward healthcare providers with incentive payments for the quality of care that they provide. And it's not just for people with Medicare, but it's really across the board. And so it's part of a larger strategy to say we need to change the way in which healthcare is delivered and paid for to be able to get better value out of it. And that's what we're really looking for. But at the end of the day, value-based care may be a relative term depending on your perspective. And so patients may have one view of that, healthcare providers may have another, financial people in the system may have yet another perspective on what that is. But it really comes down to change in behaviors. And so you have to say that the value in value-based healthcare looks at what is that perspective value most, because that's will be how we define it. So with the establishment by the ACA, CMS in the Innovation Center has been running pilot programs for over 10 years. They call them models to look at different ways that they can approach this type of care. And they may improve the care, for instance, by getting doctors to talk to one another and coordinate care, which wasn't typically happening outside of certain institutions. There's also a focus on the individual receiving holistic care and addressing both medical and perceived non-medical needs, although one could argue that any non-medical need really turns into a medical need because of the impact. For that reason, at the end of the day, really what value-based healthcare is focusing on is desirable changes in the behavior of providers. And the way in which that we'll measure this in the American system is through money. So we have to talk about reimbursement. So you'll often see the term value-based reimbursement, VBR, interchangeable with value-based healthcare, just depending on which aspect we're talking about. But you can see that the study of the American Academy of Family Physicians showed that 49% of the practices of primary care doctors in 2023 were involved in some form of value-based care. And in that thinking, healthy patients are good for business. So there's that shift to how can we be preventative? And to do this, they usually utilize a primary care physician as the quarterback or gatekeeper, so as to have some control over the system. This is really a outgrowth of the managed care system, which set that up a long time ago, and it's just come back in another format. In 2020, Deloitte did a survey of U.S. physicians and revealed that 70% of physicians recognize that they have a role in managing the costs of healthcare, but that they don't have the tools. In other words, we know we have the responsibility, but we don't know how to do it. And quite frankly, cost data where the potential penalties were not provided in many cases, where the physicians were not aware of it. So what do the models do? The models present both the downside and the upside risk. But from a payer perspective, where the engagement is very high, they view it like a casino. They see this as upside only because they're going to win no matter what. If they can get increased quality of care, we're going to have lowered costs because we're going to have to provide less care across the board. On the other hand, if we don't get the desired increase in care, we can apply a penalty and see a less reimbursement being done. So it's a win-win on the payer side as they view this. One of the reasons that we're seeing an increased interest in the value-based healthcare process is because of the issue of physician burnout. And I call it physician burnout, but it's really applies across the board for all healthcare providers. Nurses are burning out at a rate equal to, if not exceeding, what physicians are, and so are all the other healthcare providers. But what are the reasons for this? Well, it's noted that it's the burnout causing decreasing access to care because we're running out of providers. But the cause of burnout is really there's a perceived lack of time with patients. So the ability to deliver high quality care seems to be inherently limited because of that time constraints, and that there's an increase in burdensome administrative tasks. And a lot of times this is viewed through the lens of the electronic medical record, which seems to apply a great onus or burden for people. So the feeling is value-based care could help reverse this trend, decrease the burnout, and increase the access to care. There's a number of programs, and this is a very complicated slide, which we won't go into great detail, but suffice it to say, this is the federal programs that have been developed based on value-based care in the last 10 to 15 years. And you see on the top line is the actual legislations that were passed. But the second line, which is the more important for our talk today, are the various programs that have been instituted to create many different avenues for carrying out value-based care. We're going to focus on one of these just as an example. These are very detailed, and to spend time learning all the details of each of these takes a long time, way beyond the scope of what we could cover in today's talk. But I'd like to focus in on the MIPS, which is the Merit-Based Incentive Payment System, as an example, just to give you an idea of how this might work. So the first thing is MIPS can be accessed either by individual providers or a group, and they have to determine their eligibility. Oftentimes that eligibility is volume-based, meaning that you have to do a certain amount of work to rise to a level where you can participate in these programs. You typically are given a number of measures to choose, and you can, as a group or individually, choose which measures you're going to participate and report on. Then the data on these results are extracted either from claim submissions, electronic medical records, or a combination. These then are tabulated and scores are given, and the score is given in a range of 1 to 100 points. If your score is 0 to 18.75 points, then you get a maximum penalty of losing 9% of the reimbursement. If you're at 18.76 to 74.99 points, the penalty is a sliding scale from 9% up to 0. At 75 points, you're considered neutral, and so there's no bonus or penalty given. And then from 75 points and up to 100, it becomes a sliding scale up to a maximum of 9%. So you can see that there's a swing from -9 to +9, or 18% of reimbursement can be up for grabs in some form or another under this system. So what does that look like? Well, I chose one example, hip arthroplasty. There's approximately 300,000 cases per year that are done of hip arthroplasty in the United States. And the typical reimbursement for a bundled procedure is between $3,000 and $10,000. What does bundled procedure mean? It's that the reimbursement actually gets combines both the physician provider and the institution or site will get a single amount of money that then gets divided. Typically, a physician share is in the range of $1,375 to $1,450, and the reimbursement, let's say, is $7,500, which means the hospital comes out with $6,050. Let's say there's either a penalty or bonus of 9%. That would come to $544.50 per case. Or if you total an institution that's doing 300 cases a year, it'd be $163,350 per year. You could imagine an institution losing $163,000 to the bottom line is a significant hit to the operating margin that institution has. On the other hand, it could be a significant addition if you can get the bonus. And this is just for one procedure. So if you tabulate across the board all the procedures, you can see the major effect that this can have on institutions that, quite frankly, the usual or average hospital is operating somewhere in the 0 to 5% margin rate, which means they don't have a lot of room to wiggle. And if they start getting hit with a lot of penalties, that could be disastrous from a financial standpoint. So that's a quick introduction to the implications of some of these programs that have been developed on value-based healthcare. I'm going to turn it over to Joni, who's going to pick up the impact.
Thank you so much, Dr. Smith. Well, now that we completely understand everything we need to know about value-based payment and value-based care, little joke there, I'm sure you do not. We're going to move into how this impacts our organizations. So now that you have a really good overview from Dr. Smith on what it means and what the definitions are and perhaps how you might be paid different, we're going to talk about how all of this impacts your organization. And frankly, a lot of us are feeling a little shell-shocked. We just came out of the pandemic, and we were burnout, stressed out, trying to deal with everything we had to deal with through that pandemic. And now for this past couple months or year, we've been moving quickly and escalating into value-based payment and a lot of new terminology. So if you feel a little lost, you feel a little shell-shocked, you're trying to wake up from the pandemic, don't feel alone. So these 3 areas are what we are going to recommend today. We could talk about 20 areas, but these are the top 3 that we chose to talk about that you might want to take a look at in your organization as far as impact. So the first one is education. Just like we did in this first segment, we tried to educate you on value-based payment and value-based care. So let's talk about that first one there, education. Just as I said, everybody coming out of the pandemic, everybody hearing all these new terms, there's approximately 62% of the C-suite itself in hospitals that do not, and even with payers, that do not understand or fully understand value-based payment. They may have heard the term, they may have an idea of what it's going to be, but not everybody gets it yet. So one of the top priorities in your organization is to educate everyone on this. Not only the administration, the C-suite, the providers, but also patients and others in your organization. So patients will be receiving healthcare under these models moving forward 100%. Medicare's goal for 2030 is that 100% of providers will be paid by these models, by value-based payment. So patients, 2.3 million right now over the past decade have moved to these arrangements. They may not even know it. And then as of 2022 and now 2023, it's rose a little bit, I think 75% or so. The Medicare Advantage patients are fully aligned with a value-based care arrangement. So it's here to stay. We're going to value-based payment and value-based care. And this came about intentionally. The advent of value-based care was based really on IHI, the triple aim framework that they rolled out. And this was designed to motivate your providers and your healthcare organizations to shift their focus from the fee-for-service volume to value. So for fee-for-service, we were paid based on what we did. So for fee-for-service, we were just seeing the patient, getting the payment, and moving on. It was kind of a, one size fits all. We diagnose, we treat, and then we bill for those services. With value-based payment, we're going to shift completely for that. You're going to be paid more on outcomes, not the service provided. That will be a portion of it, but you're also going to have to incorporate what the outcome of that was. So as we shift to that, the reimbursement model will have to align with your payers. So you're going to start to assume these risks. If you haven't already, you probably have already, but you're going to be able to choose different risk models, how much risk you want to take on, if it's one-sided risk or two-sided risk, and so on and so forth. So all of this is coming about, and Dr. Smith is going to touch on this a little bit more in just a minute. So one of the things you may want to consider when you're educating is all the new things that have been rolled out in the last year. If you look on the right-hand side of this, the new terminology that's out there is overwhelming. I've just given you some examples here, but you could add to this list probably 10 or 15 more terms. One of the biggest ones is called population health. That's just really taking a look at your radius of your organization. How many people do we serve within those people? How many of those have, lung cancer, or how many of those are of the age group over 60, and so on and so forth. So all these statistics are being done by your payers. They have actuaries who are actually looking at your patient population. So if you have 50,000 patients in your area that you serve, what percentage of those have lung cancer? Well, maybe if you're in Kentucky, a lot of them do, but maybe if you're in California where they don't raise tobacco, that's not the predominant diagnosis. So that's your population health. You want to take a look at who you're serving, what, all kinds of factors about that, ages, diseases, diagnoses, and so on. Consumer-based healthcare and social media is where we're moving quickly, rapidly. So if you look at the new generation, they want their healthcare online. In fact, they want it on social media most of the time. My granddaughter was talking about an influencer who told her what, medication to use for her skincare. So if you look on social media right now, if you open up, any of the social media sites, Instagram, TikTok, or whatever, you're going to have physicians on there. I'm Dr. Sue, I'm a dermatologist. I would recommend these 3 products at your pharmacy. That kind of thing is going on. This is good and bad. You have anesthesiologists saying you want to do these 5 things before you go to surgery. I'm Dr. Smith. So it's good in a sense that we're educating people more, but it can also be detrimental if the advice being given is for a profit purpose, for things that they are endorsing, or if it's wrong information accidentally on their part. So that gives you liabilities and risks. So if you're a risk manager on the call, or anybody in risk management, that is something that you might want to start taking a look at. If these physicians are employed with your organization, is it in their contract that it's okay for them to represent on social media? Also, we have Amazon, CVS, and all of these organizations outside of the hospital now providing care. I just got a new advertisement on my Amazon Prime that I can join Amazon Care. So I can get my care online. I can go to my doctor online. I can pay a fee per month to do that through Amazon. I can get my, drugs delivered to my door, and so on. This is very attractive to this new population. So we have to start thinking in those terms outside of our hospital box or our payer box. What is the patient or the member doing? They're becoming a consumer. The third one is digital front door. I'm sure you've heard this term, or you're hearing digital transformation or digital integrity. There's all kinds of terms out there right now, digital health. So this digital thing is becoming really a new buzzword, and that includes artificial intelligence, websites, mobile apps, portals, chatbots, you name it. So you may have a lot of this starting to go on in your organization. And again, you're going to have to monitor that and keep control of that as to how people access the provider in your organization there. Then social determinants are important. If you haven't heard this yet, I would be surprised. It's really been going around a lot the last couple of years. So social determinants of healthcare, SDOH is the acronym. These are factors that impact your health outside of the doctor's office, outside of the hospital, outside of your treatment. So for instance, if I'm a diabetic and I'm patient A with diabetes, I may go home from the hospital with my care plan, but I can't walk in my neighborhood because it's not safe. I don't have access to good organic produce and groceries to eat, and I certainly don't have the money to buy them if I did. I don't have transportation to the hospital. So I have a lot of factors outside of the hospital that may impact my outcomes with my health as a diabetic. Patient B may be a diabetic as well. If they live in a nice neighborhood, they can get out and walk every night, they have plenty of money, they have a car to drive. So you're looking at factors here that would impact that patient's health regardless of the treatment they're receiving. And then equality, equity, diversity, you're hearing these terms as well. And this just means we want to treat everybody fairly, regardless of race, age, background, religion. We want to make sure that no matter what, you are getting fair and equal treatment. Outcomes. How many times have we heard outcomes lately? If you haven't, you will. So again, switching from fee for service, where we're just getting paid for services, we're going to be getting paid on the outcome of those services. So how did that work for you, kind of thing. So we're going to be looking at that. So you want a structure, plan, and strategy. These are also 3 terms that have come about. We used to not have to plan and strategize for these things, but now you will have to do that. And if you don't have a strategy in place, you're looking at the left side of the equation here, you should have one. So it's not, you know, too early or too late to begin to work on that. And if you need help with strategy, we are here to help you for sure. But everybody in your organization should be a part of that. And you should be starting, or at least, you know, working on your value-based care and payment strategy. How is your organization going to handle that? And then certainly it'll impact credentialing and privileging and quality and peer review and all the other things we've listed here. You're going to have to start looking at, do we need to change any of this? Are we rooted and grounded in legacy systems? Are we rooted and grounded in legacy guidelines or policies or bylaws? Are we rooted and grounded in legacy privileging criteria? Have we looked at our privileges in the last 3 to 4 years? You know, are they the same as they've always been? So those are all kinds of things that you will need to start to look at to incorporate the right side of the screen, these new elements. And then you'll see the class survey down there too. They just basically said it's a priority now. And I'm going to switch back over to Dr. Smith for a minute because I want him to just elaborate on this underpinning philosophy.
Yeah, I just wanted to make a couple comments that Joni was alluding to, that we were moving from fee-for-service to the value-based models. And what you need to think about is the underpinning philosophy. So in the old days, fee-for-service was really based on a need for care. And the way we approached it, and certainly IHI was a major supporter of this idea, was that there were 6 domains of care that we needed to pay attention to. The care needed to be safe, it needed to be effective, it needed to be patient-centered, timely, efficient, and equitable. And it was those 6 domains that focus was turned to in terms of the delivery of care, but that was preeminent under that fee-for-service model. When we go towards value-based care, it's really the idea under triple aim is that we need to prevent the need for care. So we want to be proactive to the extent that we can be about improving health and lowering costs that will result in better care across the board. And the need to do the need for care while still present for the care that we need to deliver, hopefully will be diminished in terms of the volume. So that's just a different way of thinking about how we're making the change and the way the shift has to occur. So I'm going to throw it back to Joni to carry on with the impact.
Thank you. Okay, so we have had a good overview of what we're dealing with here, the definitions and so on. We've also talked about educating everyone on this with the new terminology and the new ways we need to incorporate it in each area of the organization. So now I want to move into an evaluation process, or evaluating where we are now. And I equate this, a good analogy, I think, is if you decided tomorrow to go to New York City. If you're in New York City, imagine LA or somewhere else, but you're going to a big city. You're going on a trip. So what you would do normally is either use your GPS if you're more advanced. If you're older in age, you might even still use a map or a road atlas. But regardless, you're going to open up your app to the chat, you know, the Google Maps, and then you're going to put in where you want to go. Then it's going to ask you what your current location is. So where are you heading out from? If you don't know that, then it'll select one for you if you want it to tell you where you're at. So you don't want payers, if I equate this to your evaluating where you are today, you don't want payers to tell you where you're at. You want to know where you're at. You want to know what your location, so to speak, is. So you want to be able to evaluate where you are right now in this process, if that makes sense. And then you can map where you're going. So as we evaluate, there's a few areas we suggest here. Again, there could be a lot more, but just to kind of start with these things and say, you know, what's going on now? What do we need to look at that we're doing well? Because you probably rock at a lot of things. I mean, there's probably some things you guys are doing really well that you could promote or demonstrate for payment. There's incentives in these new risk models, there's also penalties. So you want to avoid those penalties. So you need to understand how you're getting paid, and then you need to look at these areas and see, are we doing well here or do we need improvements? So one of those is your clinical and service integrations. Again, now everybody needs to work together. A lot of the quality directors I talk to now tell me I'm no longer reporting to the CMO. I'm now reporting to the revenue cycle manager or the VP of revenue cycle management. And there's a reason for that, because now we're not just reporting quality of outcomes and looking at the physician's productivity. We're now looking at, did we get paid? So the clinical service integrations and all of the integration within your hospital need to be working together as a team. Look at your operations and cost. Cost is one of those three, elements of the pillar that Dr. Smith was talking about. So we want to be cognizant of that cost, and we also want our physicians to be cognizant of the cost. Outcomes tied to performance. We've talked about that. If credentialing is not privileging. So, and quality certainly privileging should rely upon quality outcomes. So we want to look at performance. I may be able to play the piano. I've had piano lessons, so I'm certainly credentialed to play the piano. I might be invited to play at certain halls or, sites or concert halls or whatever. That's my privilege to go and play there. So I've been invited, just as doctors are invited to have privileges at the hospital. But once I start playing the piano tonight, if I don't feel well, or I see somebody in the audience that freaks me out, or, the audience doesn't seem to be responding to me, my performance may not go well. So again, we need to be looking at the performance and then the outcome of that performance. Did some of the audience members start to leave? What's going on? So we want to look at that overall. And then does your data give you what you need? And this is huge. We have so many disparate systems out there right now, and everybody has a plethora of data is what I'm hearing, from quality directors and people I work with. They're like, I've got all kinds of data. I've got data. I just don't know what to do with it. I don't know how to demonstrate with it. I don't know how to aggregate it. So that's something you might want to start taking a look at. Probably have already with all this digital front door and everything going on. And then always identify areas in your organization that you feel like, we're evaluating this and this looks pretty good. We're doing pretty good with education, training, CEs, things like that. But this area we question a little bit. So, feel free to get buy-in from everybody, question things, clarify things, analyze things, and then create. Don't just stop there. Make sure that if something doesn't line up with the other side, you're creating and taking action on it. Another area you might want to evaluate that's outside of the box a little bit. A lot of organizations stay within their walls, stay within their activities, their, surgeries, whatever's going on inside. Start to expand your circle a little bit and start to look at your relationship with payers and employers and the community. So you want to partner with these folks. And a lot of time you don't have the ability to do that. So you need to figure out how you can do that. You may not always get direct feedback from employers that have the employees that are with that plan or with that payer. So you might want to engage the payer and ask for that feedback. A lot of times the payers will give you feedback, but you just accept it, star ratings or whatever they're telling you, you just accept that information as verbatim. That's what we're doing. I would question that at times and make sure it matches up with what you think you're doing. Half of the physicians are employed right now, either through payers, which could be group model, staff model, HMOs, or through hospitals, or through physician groups. So half of the doctors out there are now employees. And it's really important too to understand that as you evaluate your physicians, an HR evaluation is not the same thing as a clinical outcome evaluation, FPPE, OPPE, peer review. And I've had people recently that are doing telemedicine or they've got employed PCPs. They're like, well, they're employed, so HR takes care of that. No, I mean, they might need an HR evaluation for employment, but there's a contract there between that physician and the organization. And you need to review that contract because 50% of those contracts are now currently value-based. So if the contract with the physician and your organization does not include some elements that you're trying, some of your objectives and goals that you're trying to reach with this value-based payment, I would encourage you to take a look at those contracts and consider incentivizing those physicians more in those agreements between you and the physician to do that. And again, these reviews that you're doing with your providers could be from many different types of organizations. So your review in an academic medical center may not be the same as in the military, but there are certain components of that that you can start to look at and maybe update to incorporate some of this. Now, why do you want to partner with the payers? Because the payers are your bread and butter. So if you have 50,000, members in your area from commercial payers or from Medicare, Medicaid, you want to make sure that you retain those 50,000 members and keep them in your, you want to be in that network, so to speak. So partnering with that payer as much as you can is going to become more and more important. If you have perks in your hospital that you can provide through that payer to those employees or members, just really promote those. We have a great program for new mothers, here, and we want to make sure you're aware of that. So start to think about how you can promote yourself to these employers and to these payers to get some of those new incentives. Also, what is important to the employers right now? Why are they choosing your network? Why are they choosing to have a PPO instead of an HMO maybe and go outside a network? You want to keep them in there where you're at. So know that every dollar that's spent on healthcare is $2 to $3 lost in productivity. So employees are very, very concerned about this. And with all of the new laws and, all of the new divisions of HR now that have to attend to people's feelings and things that we used to not do in the past, people can get off work easier now for things. So this productivity is really big. So also the moderation of cost, the premiums they have to pay and things like that. And then you want to attract and retain the workers. So again, go back to the perks, how can we attract more people? And if we have programs or perks in our hospital system that would be attractive to these employers, let's get it out there. As you do your provider performance reviews, whether it be for your APPs, your nurse practitioners, PAs, or for the physician, these are some of the things you might want to keep in mind that are new. And I would encourage you to start to incorporate some of this if you have not already or already don't do this. So include those outcomes and that data that provider can trust and give them that data on a regular basis. Don't wait 6 months until it's time for OPPE to say, oh, by the way, you're failing. You have too many readmissions. You have too much of this. You have less of, don't hit them with a ton of data and tell them everything they've done wrong at the last minute. This should be done on an ongoing basis, and those providers should be supplied with outcomes data so that they can adjust their behavior as they go. Focus on retention and physician buy-in. You want to retain your providers. We have one physician a day committing suicide right now, and we've had hundreds, if not thousands, of providers leave the healthcare industry. So there, as Dr. Smith was talking about earlier, there's really burnout right now. So you want to retain them. So I would include them in their performance review. What would you like to see us change here? We've done it this way for 10 years. Is there something that we're not giving you? Is there something that you think we should be including? So get that buy-in with your doctors. And then if they're doing anything with health improvements, disease management, preventive care, any of these new areas, certainly include that in the evaluation. The patient experience is different now. It used to be, patient satisfaction. Well, yeah, I was satisfied with my surgery, and that's about all you got. You might have used a Press Gaining survey or something like that. Well, now this new generation wants more than that. They want Starbucks when they come to your hospital. They want pretty plants. They want a jungle gym for their kids. I mean, there's things that this younger group of patients are looking for as an experience versus just satisfaction with their treatment. So keep that in mind. And then cost efficient indicators, we've talked about this, how do I utilize resources as a provider in your organization? Do I know that? Have you given me that information? And then adherence to standards and evidence-based guidelines. Have I followed that? Am I adhering to those guidelines? Because all of that will result in your ratings with these accrediting bodies and with these payers. It'll also be resultive and reflective in your payment. population health, telemedicine, and those other holistic elements I was talking about earlier, all of this should now start to be included in the provider's review. So those are just a few tips that you might want to consider with quality. So now let's move to assess, excuse me. So we want to start looking at how can we demonstrate things, what's going on now as far as what we need to do. So this is a great survey, in my opinion. It's a Becker's healthcare survey, and they don't have the 2024 data yet, but I'm sure it's coming soon. But this is last year's data, basically. So they asked, how did your hospital, health system, or practice claim denials rate in 2023 compared to 2022? And 71%, almost 3/4, said that they have increased. 12% said they decreased. And then no change also included, I don't know. So it's either it didn't change, or I'm not sure if it did, or I don't know how to find out, or I don't know. So I wanted you to think for a minute. If I were to ask you this today, where would you say your organization falls? And, some of you may say, I don't know, which would put you in the 17%. Some of you might say, I know it's increased. So this data, this claims denials, there's a reason for that. So let's talk about that just a little bit. So you need to be able to demonstrate what you're doing well, and you need to be able to demonstrate what you're not doing well and what you're going to do to improve upon that, which Dr. Smith is going to elaborate on in a minute. So you want to be able to have some type of illustration with payment. It's not piecemeal anymore. I used to be a quality director in a hospital, and I worked on the 3rd floor. Med staff worked on the 1st floor by admin, and then we had billing claims and everything across the street that we outsourced to some group. So I never really talked to the billing and claims people. So there are coding errors and things like that that come into play. But you also, don't want to be on an island with each department trying to figure out why you're getting claims denied. So be able to track this and discern, what percentage of our denials are due to coding errors, or what percentage of our denials are due to the fact that we just couldn't prove we did this well, and so on and so forth. And then review those managed care contracts. Those are so important. And I could spend an hour on managed care contracts. But if you don't have somebody in your organization who are reviewing these on a consistent basis, not once a year, not annually, not every now and then, make sure that you get that taken care of, and you start to look at those on a more regular basis and compare your outcomes and your claim denials to the contract and what you were supposed to do that maybe you didn't do well. And then demonstrate to the providers themselves those outcomes and reimbursement information. We had 20% of your claims denied, and we found out it was because of XYZ. And if you could help us with that, that would be great. So you can incorporate that back into their review as well. 85% of hospitals have the capability to export data for reporting and analysis purposes. So you have this data. But according to ONC, the Office of National Coordinator for Health Information Technology, they're reporting that even though 85% have this, there's really no standard approach to using it. Or to validating best practices. So this guidance may help address the unmonitored handling of secondary health data. So just know that, 85% of you probably have that data, but you really need to look at using it better. Oh, and this came from Joint Commission. I need to give them credit. All right. I'm going to turn it back over to Dr. Smith, because now that we have all of this information, what do we do now? We need to improve and come up with our strategy and action plan. So Mark, you can take it back.
Thanks, Joni. So hopefully you're not too discouraged over all this, but we did want to leave you with some thoughts on how we can improve and what things we need to focus on. So this may seem a little bit of a rehash because we've alluded to a lot of this through the talk, but the significant areas that we see is, one, that there needs to be integration between the clinical and other services in an organization. And that requires a focus on everyone, and especially looking at having engaged providers, looking at the group that you deliver healthcare to, and having an effective network in terms of managing the healthcare. This all goes into the ability to answer the call to value-based care. operations that include member engagement analytics and technology risk adjustment, and quality, all are part of this that need to be looked at and fine-tuned. And then from a financial standpoint, you need to engage actuarial services, risk models, strategy, and compliance so that you can be predictive if you're moving in the right direction. You don't want to wait to get the actual penalty applied if you can head it off at the pass, so to speak. So in essence, you need to check on your effectiveness, your operability, your efficiency, and especially you need to be flexible and adaptable in all your systems to be able to answer the call. Also, be aware of the new trends that are out there. Certainly, our workforce since COVID has changed the way in which a lot of the workforce applies work, and this is filtered into healthcare, even to the point where telehealth and remote healthcare is becoming a major component, especially in rural health areas. Behavioral health as well is rising. We've had a decades-long ignorance of behavioral health, and we really need to apply more resources in that area as it seems to be becoming of increased importance. The effect of artificial intelligence, we don't really know where this goes, and we do know that it's going to be wide-ranging and we need to consider it. Remember that boomers are coming along as a very large group, and the burden of Alzheimer's is increasing greatly and straining our healthcare platforms. And social media, which didn't really have a big impact, now becomes a primary place that you have to pay attention to because reputations can get destroyed in social media. And that may be apart from the reality of the situation. So you have to monitor these things in today's world. So what do we need to do? We need to consider the outcomes and look at how we can achieve the best possible outcomes, take advantage of your internal expertise to help everyone improve, to see who's doing things really well. For a long time, we were always focused on who didn't do things well and worried about that care, but we really ought to be looking at trying to achieve the best possible outcome, and maybe we can learn from one another. Recognize that quality, credentialing, and privileging are a continuum. They are no longer separate actions or processes, but they're really on an entire life cycle of provider performance, and you need to be able to have them work in conjunction with one another smoothly to be able to give us the correct information going forward. Recognize that we need to engage the consumers, employers, patients, and their families, and you leverage your community resources to the extent possible so that we really can create a program that will meet the needs for the healthcare of your community. Provide connection between providers and patients. This is especially important with younger patients because they don't go by the old model of you come to the office and deliver your healthcare information in person. They're much more digitized, and you have to have that to be able to connect to them. And you have to consistently review your outcomes. You don't want to wait on this. You can't go every 2 years. This needs to be an ongoing process that we look at and constantly are aware of potential downsides that we need to deal with. And review the reports that are out there and know that there's a lot of ratings. The STAR reports, STAR ratings, by the way, come both in managed care plans as well as hospitals, and the HEDIS information through NCQA of performance by health plans all impacts on our ability to be recognized under the value-based healthcare models. And as Joni talked about, the contracts and the models are very important in terms of determining what we're going to do as an organization. So I'm going to leave you with what we saw as an action plan to meet the value-based care challenge, and hopefully this helps you to think about organizationally what to do. From an organizational standpoint, make sure that the issue of value-based care is part of the organization's strategic plan, and so that it fits in and that the proper resources are going to be delivered to carry out value-based care on a regular basis. Next would be to audit the services that are potential value-based reimbursement candidates. As you heard, Joni talked about, eventually Medicare wants to get to 100% across the board, but for right now, there's still some selection that can happen, and you may want to be aware of what you're doing by services. And then you're going to have to assess your organization and your provider's ability to participate. Do we have enough volume in this area to be able to meet the particular programs in the value-based care? Then you do an analysis of the potential gains and losses for reporting in these areas. What are our outcomes today, and what can we expect to be able to score? And that helps us to selectively decide where to put our resources to make improvement. There'll have to be a lot of education of the providers in terms of the relevant performance elements and how to go about getting improvement in those areas. And so you need to be able to have a plan for implementing performance improvement plans on a regular basis. This needs to not be seen as punitive, but rather as additive in terms of the healthcare that's being delivered. And finally, this is very dynamic, and these programs change on an annual basis, if not more often. And so you have to have it at a minimum, an annual reassessment process to look at the programs and areas in which to participate. From a medical staff level, the implications we think are in the following areas: that privileging criteria that have been developed need to be looked at with an eye towards the value-based care requirements so that they're in alignment. You don't want to set privileging criteria that go counter to what is required under value-based care. You want to align your performance metrics to consider the appropriate value-based care measures so that we get the right information to be able to act early. And then you have to proactively commit to performance improvement plans when need is identified. To that end, we think that each organization will be able to do that in a standardized way. So these are our final takeaways and thoughts. Joni, I'm going to let you have first crack at final thoughts and takeaways.
Okay, thank you. All right. So first and foremost, value-based care is here to stay. Value-based payment is here to stay. Value-based is here to stay. So it's gaining momentum. It's increasing in relative importance. So, for us to stick our head in the sand and hope it goes back to fee for service is not going to happen. Really, fee for service, I always say, is the chassis, on the vehicle. And then the new model that you lay on top of that chassis is going to be value-based care. So or payment. So even if you have, that foundation with fee for service, you can build on that. So I think that's kind of exciting. If there's things you're already doing well, like I said, do that and build on that chassis. Having a value-based operational structure that's reflective of your population that's being served is a great key to success. We talked about population health and so on. That's slow moving, but you have plenty of time to prepare to demonstrate those things. So if you can relate your outcomes and the things that you've done well to how that's helped the population as a whole, that will be very effective. And then optimizing performance in the value-based care environment, it just requires everybody, really. Management needs to focus on that continuous improvement that we talked about. And then healthcare is evolving at an accelerated rate. If you don't feel it, we're just flying right now with all the AI and everything going on. So those still incremental, the rate of change is just fast paced. So, hospitals and health systems have become the largest employer right now of physicians. That's another key tip and takeaway. So you really can work with these employed physicians, engage them, and get their buy-in. And then on the right there, we just gave you some tips to think about. So just want to thank everybody for joining us today. I'm honored to get to speak with you and do this with Dr. Smith. So thanks, everyone. If you do have questions that you want to ask, I'm sure you can put those, as Sharon has said, in the Q&A.
Yeah, we have a couple. Yeah, we got a couple questions we're going to get to. So I'm just going to kind of start firing away so we can get through everything that's been submitted. So one question we had is there a standard percentage of physician compensation that's tied to performance-based goals? And then does it vary by specialty or by market? So like urban versus rural?
It varies. There is not a standard yet. that I'm aware of. Dr. Smith, if you are, let me know. But that may come about as we see the outcomes and how things are paid. But right now, it does vary by a lot of things, and that's the good thing. In your organization, you can set those percentages. You can negotiate those percentages.
Right.
Yeah, yeah.
Um,
For the list of things that you said, Sharon, it's all the above. It varies by program. It varies by particular service. So that's why people need to be aware of the details, because there's no one set standard. But I can tell you that the one generalization you can make is that there can be a significant penalty for not meeting the criteria. So you need to be active in paying attention.
right. Okay, we've got this one here. This person is part of a highly developed healthcare system. The clinics tend to act independently of the hospital, which is sometimes appropriate, but can also be problematic. Any suggestions on how to approach this for better communication?
I'll take that one. I think physicians' autonomy has been a problem, quote unquote, in being a physician and maintaining my own autonomy. I recognize that it's part of the tensions that's there. What you really have to do is educate people and include them, make them part of the process so that they get to have their say. I think where most physicians will rear back is when they feel like things are being imposed on them. That's one of the reasons why electronic medical records are usually viewed with such suspicion, because that's usually viewed as something we had very little say in and causes us a great burden. So I think it's be proactive at having those discussions, including people, and I think you can break through that autonomy problem.
Right, thank you. So we have quite a few questions. I'm going to kind of take several and lump them in together because they also relate to the same theme and topic, and that's talking about OPPE being part of the provider performance for tracking purposes. And what are maybe some of the best sources for setting benchmarks for OPP measures or identifying those OPPE measures? Are there, what are there specific metrics or indicators that are critical in assessing the effectiveness of value-based healthcare that can be used in OPPE? So I think everyone's really looking at this through the lens of an MSP, all right, and OPPE and monitoring our physicians. And how do we get, for lack of a better term, best bang for our buck, right? What metrics can we measure? What are the most critical? Are there ones we can use that we already have so we're not creating more work? What are your thoughts there?
I'll just start out with a few thoughts and then let Dr. Smith join in, I'm sure. So first of all, keep in mind that your physician review process depends a lot upon your accrediting body, for one thing. Joint Commission is OPPE, whereas DMV and some others may call it something different, but there is that annual ongoing review. There are usually 6 standards there that are followed, length of stay, readmissions, that kind of data that comes in. FPPE is also an ongoing review where you can take a look at factors that come up. You're going to do initial FPPE just to make sure the physician is adhering to the privileges and the guidelines and things, but you may have ongoing FPPE as well. Something's happened, something's occurred, we need to assign another physician for proctoring or whatever the case may be. So there's simulations, there's proctoring, there's different types of reviews that can happen. But yes, all of these, as well as peer review, which is so important, need to be incorporated in value-based payment and review as well. So we want to take what we're currently doing with the measures and things we're tracking, but we also want to keep in mind, if you remember, I said we want to think outside the box a little bit. We're looking at the performance, we're looking at RVU sometimes, we're looking at productivity and these 6, standards and things like that. And that's all good data. But we also want to make sure we're looking at the outcome data, the patient experience, the things outside of what the physician is actually doing procedure-wise, if that makes sense. So that answers,
Great,
I think,
thank
part
you.
of it.
So, yeah, so, I probably need 6 or 8 hours to really answer that question, and I won't do that, but
Well, maybe we can just ask you to put up your contact information information on the next slide. So if
Yeah,
people have
but
follow-up questions, they can reach out
yeah,
to you. But tell us your
but
2-second response.
yeah, so I think it's important to recognize the change. The change that's occurred is that we used to have a complete freedom of choice of what to look at. In other words, the accrediting agencies and other places would say, you know, you got to do it, but we're not going to tell you what to do. You go pick the things that you think measure performance, and you can look at it, report on it, and we'll make sure that you do that across the board. I think with value-based care, we're starting to see some impediment on that freedom. In other words, I think there are certain things that are becoming so important that everyone's going to have to think about, including those measurement metrics because of the impact that they're going to have financially. So I think we're moving from sort of complete autonomy in choosing performance to having some imposition. And in terms of benchmarks, there's not a lot of national benchmarks that are out there that you can really hang your hat on. Certainly cardiac surgery with the Society of Thoracic Surgery database is one of them, but we don't have a lot of national databases to give us true national benchmark standards, but they're coming. So you just have to keep an eye on it. But until that time, you still have, again, the freedom to choose those goals that you think are appropriate.
Perfect. Thank you. So another question here. So are the HCA, HPS scores part of the reimbursement models? Does that get factored in?
I think under certain circumstances they are. Joni, I think you might know more about
I was
that.
gonna say the same thing. It's by contract, by agreement, you know. So you
Okay.
really, it goes back to what I was saying earlier, you know, with all these things we're talking about right now, with all these questions, everything has to be, it's cyclical. So, you know, you have to look at, why do we get denied claims? Why aren't we getting paid? You know, and then back to, what do we need to measure or do differently based on this new incentive we have, or this penalty that we got, you know, those kind of things. So it's all just a big circle, in my opinion, of continuous review. You know, what do we need to change in the privilege criteria? Potentially, what do we need to change differently in our review of the physician, so that they understand that that outcome, the reason we didn't get paid, was because of XYZ that they could help us with. So, you know, that kind of information is what I would encourage you to continuously review and look at, because you're going to get paid differently by payers based on different criteria, different penalties, different incentives as we move along, if that makes sense.
Yeah, that's great. You know, and I think, so this next question really talks about the players in all of this and the stakeholders, and what role does the MSP play in this process? Because if it's not in place already, what is, you know, an MSP, or as someone who's attending our webinar today, what can be done to initiate it? Who are the stakeholders that really need to be involved? Who owns this process in the hospital? Like storage of data, HIM, is the business office, quality, MSO. My guess is it really goes across a number of different departments, right? It's just very much so this interdepartmental type of program. But I think if we could give people maybe a few tidbits in how do you get started? How do you initiate it? How do you talk about it? Because we're talking about real money, which always gets the attention of the CFO and our CEO, right? But maybe where's a good place to start?
I'll give you an example that was told to me by somebody who did this well as an MSP. So I'll use her. I won't mention her name because I haven't asked her if I can, but she told me, she said, I took all this, you know, that I was learning from you. And she said, I just went right into, because, you know, to me, MSPs are heroes. I mean, they're really the, you know, the rock of the hospital. Everybody talks to them, everybody comes through, you know, talks to them, and they're kind of the orchestrator of the whole thing, in my conductor, I should say. So you know, you can be the hero in your organization. What she did is she put together a Tuesday night forum, she called it, which was a meeting. She It's funny, but she went around to Panera and a couple other restaurants and asked for any donations for danishes, donuts, anything she could have as far as refreshments. And she invited people from each department to come and give their feedback on what they felt like needed to happen as you move forward with value-based care and payment. If they were knowledgeable, or if they just wanted to learn more, or if they had some feedback, or they had questions. And she said, I just let it be an open forum, and I fed everybody. And she said it ended up being great because I had different people from different departments, and it wasn't always the director. It might be just the person who's doing the work, under the director. And then she would have a doctor attend sometimes, and then she even invited the community. So it was interesting, and I thought it was a great idea. And she said it really worked well. And then she had the CEO step in and say, what's going on? What are y'all doing? Kind of thing. And she said, so I invited him, and it just kind of went from there. But she apparently had a lot of leeway to come up with some ideas here. So that's just one example. But
That's great. I love that. Well, if nothing else, MSPs are creative, right?
yes, yes.
So
Resourceful.
let me chime in a bit. I think MSPs need to do what they always do. And that was one of the reasons that we wanted to give this talk today, was because if they are aware and knowledgeable about what's required, they'll get it done. They'll make sure that it gets put into the process, because they act as the conscience of the medical staff, and have the ear of the medical staff leaders. So I think that's what they do. What they'll do is they can assess whether these items are being considered by their organization. And if they're not, they can put the bug in the ear of the right people to say, we need to consider this. And they'll be able to see the outcomes, because they get all the information around the other end when they get performance information back for approval and recommendations. So I think that's where we see the great value of the MSPs, is that they function sort of under the undercover, but obviously have a great effect on it.
And diplomacy, I think.
Yeah.
She also said to her CFO, she said, I have some ideas where how we can make some more money coming
There
up
you
with
go.
value-based.
That always gets
So that
gets
got
their
his
attention
right
Yeah,
away.
absolutely. All right. Well, thank you both so much. And thank you everyone again for attending today. Mark, if you want to just boot to the next slide here, your contact information will be up there. Please feel free to reach out to any of us with any questions. We're always happy to help. And again, your email will come directly from Hardenbergh. Your thank you for attending email will come directly from Hardenbergh in the next 48 hours or so. And again, it'll have your CEUs, it'll have slides and a brief survey. So thanks again, everyone. We really appreciate you joining us today.
Thank you.
Thanks. Bye.